I've been a mediator for 18 years and I've helped people resolve all kinds of disputes. Conflict is normal. An important thing to remember though, in conflict resolution, it's up to the participants to solve their own problem. Sometimes they just need a little help. The goal in dispute resolution is to move the parties forward so they can picture what their life will look like without this dispute hanging over their heads. Their future without this conflict is a great motivator. As an advocate or family member of a patient, we're sometimes asked to attend family meetings. The meeting is usually requested by medical staff to discuss a treatment option or some other issue and they can often be very contentious. How do we navigate these choppy waters as a participant or a peacemaker and guide the disputing parties in helping themselves to get medical answers they need? Mediation is one way. So what is mediation? The short definition is the process of shaping shared solutions. The long definition is mediation is a confidential and voluntary process where an independent and impartial third person empowers the participants to find a mutually acceptable solution that meets their interest and needs. The mediator is not a judge and does not impose solutions on the parties. If the goal is to make a decision about a treatment option or to resolve a conflict among staff or family, one way to achieve the goal is through mediation. Studies show that one of the biggest sources of conflict in an ICU is among family members. And conflict often begins when families disagree about goals of care or withdrawing life support at the hospital or the individual caring responsibilities among the family members. Conflict often arises as a result of people witnessing a loved one suffering and anticipating their death. Often these disputes are rooted in childhood. Family dynamics play a huge part in these conflicts, and bad feelings from old hurts usually do not improve when siblings age. People often get louder and more entrenched in their positions. But is there a better method than mediation? Conciliation is also one under the umbrella of dispute resolution. In the short definition, it's a shaping shared solutions plus mending relationships. So that's the added bonus. It's a process where a neutral third party encourages disputing parties to discuss their differences, identify the issues in dispute, improve their communication, and explore possible solutions. A conciliator can be anyone with skills to facilitate a conversation between parties, and that includes a family or a staff member. If the parties have to keep dealing with each other, conciliation is as much about restoring or mending relationships as it is about conflict. So I've done this chart to show the differences between mediation and conciliation, and they really are two different processes. And the differences are important. Conciliation is less formal than mediation and a more flexible process. There are no strict ground rules, and location is typically in a hospital conference room, not what most people would consider neutral territory. Ground rules set the tone and maintain orders, typically. And by the way, I only have, well, two actually. One is don't speak when someone else is speaking. I can't hear two people speaking at the same time, and neither can anyone else. So one person speaks at a time. My other ground rule is phones, and I really ask people to shut their phones off. In a hospital setting, that's kind of difficult because there are doctors on call and sometimes they have to answer a page. So, but for the most part, ask people to silence their phones. And another thing in mediation is the agreement to mediate. In conciliation, there is no such thing, no agreement to mediate, no opening statement. Those are two hallmarks of mediation. Conciliation is less about process and rules and more about trade-offs to reach a consensus. Mediation is voluntary. People are not forced to participate. I get that question a lot. Can I make my sister go to mediation because she's stealing money from my mother, whatever the reason. No, you have to come to the table voluntarily. And you can leave the table whenever you want. If it's not working out, out you go. Parties can probably leave a family meeting, but the stakes are so high sometimes, like deciding life and death issues, it would be difficult to do that. The mediator is neutral and impartial and usually has no ties to either party. A conciliator can be someone from the family or hospital staff, such as a social worker or a chaplain, as long as they have the necessary skills to facilitate the conversation. Mediation is almost always confidential, and I will go to my grave with some of the cases I have done where I can't repeat it outside the room. But in a hospital kind of mediation, it's kind of, conciliation, it's not important for confidentiality as much as it is in mediation, and it's probably not even possible. Not all the decision makers may be in a room. A family member with considerable sway may be out of town. A neurologist might be in surgery and we only have his report to look at. Both these parties and many others, like a head nurse who's on the floor, may need to be consulted and informed about the discussion. In mediation, there's a signed agreement if parties reach a resolution. Sometimes a court is involved. In conciliation, there's usually just a commitment to act, such as to put in a feeding tube or do additional chemotherapy. There's never really a formal agreement. In mediation, the goal is conflict resolution. In conciliation, it's restoring trust or repairing a relationship, and that's just as important as the resolution. Here's some peacemaker approaches, and I love this little cartoon. The guy that drew it is in California, and he gave me permission to use this, but I've had it many, many years because that's sometimes what it feels like when you're in the middle. If you're called upon to resolve a dispute, here are some approaches. It's important to remain neutral. If you show any bias, you undo any trust you might have established. Parties will turn off instead of tuning in. Bring your passion and enthusiasm to help solve the dilemma. It gives the parties motivation to work towards that goal. Encourage someone to express their feelings. They often lurk in the background, but they're there. If you validate those feelings, it can open the logjam and lets the other person see another person's point of view. Be curious, always be curious. It's one of the things I love about my job. I'm kind of a professional snoop, and I get to ask questions of people about their situation and find out what their perspective is. But don't try to figure out anybody's motives. If parties suspect you're questioning their motives, you'll lose their trust. Always assume they have the best motives and intent. Your techniques must be genuine, or they may have a negative effect. Show respect for patient autonomy by finding and following the views of the person who can speak best for the patient. That might be a surrogate, power of attorney, or someone else in the family. That's why it's so important to have all of the stakeholders in the room. This is like the planning that goes into a clinical family meeting. It looks sort of like a Rube Goldberg thing, but actually there's a process like everything else. If you follow the process and the steps, you'll get through to the other side. In a family clinical meeting, the first step is the planning, the welcome, the intros, and the planning includes pre-planning on the part of the staff to make sure they're all on the same page about the medical facts and the meeting goals. You don't really want to be in a room where 5 specialists are arguing about the best treatment. They need to be on the same page before they even get in the room. Welcome, intros include the role of who's there, from the staff, from the family. You want to know why everyone is in the room. Explain the goals of the meeting and acknowledge the topics. Explain they may be unsettling and challenging. These are hard things to talk about. 2, check that each family member understands the illness and the patient's prognosis. Listen intently, completely, always be present and in the moment. Your goal is to create a safe space and have an open dialogue. Check for the consensus about current goals and care and symptom management. Are the people aware of the timeline and the level of suffering? Not everybody in the room may be. Remind them that everyone's goal is to help the patient. That's truly the bottom line. Identify the family concerns about treatment options and have staff clarify what each option will mean in the patient's care. Clarify the family's view about what the future holds based on a particular option that they choose, or in choosing no treatment at all. Ask family members how they're coping and feeling emotionally. Embrace the emotions, respond empathetically and with compassion. Again, difficult conversation. Try to put yourself in their shoes. Help them acknowledge their worst fears. When fears are out in the open, they can begin to be dealt with. Don't push the family, give them the power to set the pace. Lack of control is a big issue in these situations, and setting the pace gives a little back to them. Summarize what you've heard. It keeps the conversation on track and gives voice to the most important issues at hand. It lets the person know you've heard them and you get it. Be succinct while trying not to miss anything. Ask them, have I missed anything? Who will do what when? Spell out the decisions that were made. And then finally, the resolution and the action plan. What did they pick or not pick? Who will do what and when? How will the family know any outcome? Name a key contact person in the staff and in the family so they can communicate with each other and then relay the information to various people. What if the treatment doesn't work? Where do we go from here? Acknowledge uncertainty and unknowns, but never make any promises. This is a position and interest kind of chart, and you can read it and see that the positions are on the left and interests are on the right. So in any dispute resolution process, you have to start by separating the people from the problem. You do that by separating the positions from the interests and looking for reasons beneath the position. These examples show types of positions and the corresponding interests and the needs that underlie them. A position is what they say they need or what they will or will not do. It's what they are really upset about and why they're in the conflict. An interest is the need or the why that's an underlying position. It's the concern or outcome they need in order to feel satisfied. Knowing and understanding these interests helps open the conversation for potential solutions. Feelings, emotions, and respects are at the core of their interests. Fear is a big motivator. It's like listed in 2 places here, and these are just examples. Let them work through the reasons by asking open-ended questions, not yes or no questions, but questions designed to let them elaborate. Makes them think about their reasons for wanting something in this conflict. An example, please help me understand what bothers you about this situation. Now that's not a yes or no. You have to think about that. And remember, different positions can have shared interests. Uncovering shared interests will help find shared solutions. In a family meeting, members may disagree about treatment options, but they have the shared interest in doing what's best for mom or not seeing mom suffer. They can work together to reach a consensus on a treatment for mom. Listening to understand, pay attention. Number 1, gather the info, listen to the speaker, don't interrupt. Listen with your whole body. Turn to the person, lean in, and it makes them feel like you're really listening. Ask clarifying questions if you don't understand something. Ask open-ended questions to uncover interests. Validate emotions that may come up when they're talking to you. Summarize to let them know you're listening. You've heard what they said, you really get it. It's important. I can't tell you how many times people have said to me, wow, I really feel heard, and all I've done was listen. Other feedback is appropriate if, once you get through with this conversation, if you want to add that. In a nutshell, Pay attention, gather info to understand, clarify what you don't understand, reframe what you think you heard, validate emotions, summarize, and finally, accept and respond appropriately. In any given meeting, there's going to be power imbalances. It's doctors against family members. So you have that imbalance of many years of schooling, training, and experience matched with, this is maybe the only experience people have with some kind of medical crisis. So how do you deal with it? How do the families come into the room? At their best? Probably not. They're experiencing fear, frustration, grief, most likely. What, if anything, do we do about this? We try to meet them where they are, accept their sadness, anger, hesitation, and frustration. Don't try to cheer them up. How do we balance the power? We acknowledge it, we talk about it. It's all about talking and having a conversation. Actually, when you think about it, the people that are in the family are the decision makers, not the staff. The family has the ultimate power in the end. How do we really empower them? We give them choices, such as setting an agenda, so they have some control. How do we shift from that uneven power to the issues themselves? You can say, I assume everyone here is going to work, is here in good faith to discuss the issues and try to resolve them. People are more apt to open up about their issues when they feel the other participants are there to resolve the issues in good faith. They need to trust that it will be a fair and open discussion. What are our best options to deal with imbalance? Knowledge is power. If possible, do your homework before you get in the room. Know the issues, know something about the participants, know the areas of commonality, know the areas where some education might be in order, both for the family and the staff. They don't really know the family or the patient very well, so they need to be educated, and the family might need to be educated about things like what can happen if you give CPR to a 90-year-old. That's an education that people have seen it on TV. It's not what it's like in real life. So that's what I mean about education. Know in your particular case, in this family meeting, where that might apply. Your job in the end is level the playing field and assure a fair process. In the Paul Newman movie, Cool Hand Luke, there's a great line. What we got here is failure to communicate. And there's a link. You can watch a 2.5-minute video to put that in context. It's really a great line. In most disputes, it's this failure to communicate that's at the heart of the problem. In a family meeting, here are some communication, almost like roadblocks. Medical jargon is second language used by healthcare professionals to shorten and ease communications. It really is a different language. In patient care, this medical shorthand can cause confusion and diminish understanding between the staff and the family. So your job, ask the staff to translate a term to remind them to use medical terms in the language that the family understands. You asking the question is like, I don't get it, so I'm guessing the family doesn't get it. And then, they're probably a little intimidated to even ask, what does that mean? Ask the staff to give a brief summary. Volumes of information can be so overwhelming, and so try to keep the providers concise. Ask them to slow down if they're going too fast. Allow time for the patient and family to ask questions and respond. Lack of time is an issue. People need time to process. Give the families the time they need to digest. When someone is about to make the most important decision in their or their loved one's life, they don't want to feel rushed. Pick a quiet, comfortable setting. Location is kind of a big deal. You don't want people overhearing this conversation. Don't meet in a busy hallway or at the bedside. Meet where everyone can sit and engage in the discussion. Be culturally aware. Failing to demonstrate cultural awareness in patient encounters is a huge problem. So Figure out who's in the room, and do you need a translator to help with the discussion? That's possible. Metaphors like fight or battle against illness should be discouraged. Studies show these types of metaphors can cause more harm than good. By describing a treatment as a battle and a patient as a combatant, we inherently set adversarial tones, and the outcomes seem as victory or defeat. Euphemisms are also problematic. Doctors don't want to say a patient is dying because they see themselves as failing. But it sends a confusing message to the patient and family. In one case, by not being blunt about a patient's imminent death, a wife continued to hold unrealistic expectations about her husband's survival. How could she make an informed treatment decision or plan for his death when she didn't have all the facts? This is a real story. She said, based on what doctors were telling her, she thought her husband had 6 months, when in fact he had less than a day. Anticipatory grief is defined as the grief that occurs prior to a death, in contrast to the grief after a death. This type of grief can be caused by expected loss of companionship, changing roles in the family, fear of financial changes, or the loss of what could be. Don't underestimate how this affects them. There can be lots of sadness, loneliness, depression, pain, anger. Fear is usually at the base. Grieving people are often exhausted and do not think their best, act their best, or remember their best in this state. What do you do when you recognize it and you're in a room having a meeting? You honor the feelings and allow the emotions that come with it. Be patient with the person suffering from it. There's a reason for it. Recognize that everyone deals with grief differently and have different emotions and coping mechanisms as a result. One person may not be affected while another person is obviously grieving. People experience this all differently. And keep the lines of communication open. How can you de-escalate anger and hostility by one of the participants? Pause and pay attention. Be patient and silent, don't interrupt. Be friendly and open, let them go. Encourage the person to tell their story. Be curious and listen to the details. Venting may be okay. This may be the only place they've been allowed to vent. Maybe their family doesn't want to hear their thoughts on this. Acknowledge the difficulty of the situation and their reality. The anger is not directed at you, so although many times it feels that way, it's not about you. Let it go around you, not at you. Once they get the anger out of their system, many times they feel better and they're more apt to have a very productive conversation. Listen for their perceptions about the whole situation. Acknowledge and respond to their emotions. Again, summarize the situation. How many times have I said that? Quite a few. So it's a process, it's a plan, it's steps, and they're all pretty much related. Once they're calm, move on to the issues at hand and focus on the future. Here's a listening triangle, and I've included this in the resources. What do you do with the silences? Or when to shut up and just listen? It's the theme of Moshe Cohn's listening triangle, and Moshe was my first mediation teacher, and his mantra was, just shut up. It's not about you or what you think, it's about them. So let them talk. Your job is to listen and learn. As a result, I don't say much in a mediation. I let the parties do the talking. Use silence to give people a space to think and react to the questions and situation. So if you can read at the bottom and the questions, you let them think. Everybody wants to fill in those pauses. Don't. Let them have time to reflect and think about it, listen, answer, and then you listen, and then you reflect back. Here's 6 ways to become a better listener. And don't you love this dog? I do. Concentrate, don't interrupt, focus on the speaker. It's a waste of time by interrupting them when really they're trying to get a point across and you're interrupting, finishing their sentence. Be present. Shut off your phone. Don't have distractions. Your total focus is on them. Actively listen with your whole body, your eyes, your ears, your mind, your intuition. Don't jump to conclusions or be thinking about your reply. Just keep listening. Ask clarifying questions. Stay curious. One of my favorite words. You're in the moment with them. You're in their head. You're interested in everything they're saying. Respond to them and acknowledge their feelings and what you've heard. And that, my friends, is the end of my presentation. And Jason,
yes.
These are some resources. They're all on PDF, so you can. I don't really know if you just put them after my talk on however you do it is up to you.
Yep.
And this resource is, people ask me all the time, what's a book I can get, about mediation? It strictly isn't about mediation, but it's about difficult conversations, and they run the gamut from your family to work to your church, wherever you can have a difficult conversation. This helps you do it.
The first couple of questions were on mediation and conciliation. As far as, is there a cost difference between those two processes, or what are the costs associated with those?
Well, that's actually a good question, because if an independent mediator comes in from the outside, they charge lawyer fees, so that can be quite expensive. In conciliation, though, if you're using a family member to facilitate or a staff member, the staff's already being paid for, their role as a staff member. So it's basically, from my experience, free. It's only when you call in a mediator where it would cost.
Yeah. What's the time, or what does the process look like? How long does it take if you're comparing mediation versus conciliation?
Well, it depends on how many issues you have in both cases.
Okay.
And if it's a treatment option, this could take anywhere from, I'd say, a half an hour to 3 hours. I mean, it won't take that long because doctors really can't sign up for 3 hours. But I would say typically, to get everything out on the table and to be talking, maybe an hour. I've been involved in family meetings myself as a family member, and that's typically how long they took. And one I can recall was a person on life support, and that one, that took an hour. So that's really not a lot of time to think about all the options, and there were many in his case, and really get through the process, because it's a process. So yeah. How long it takes is how long it takes.
Who ultimately decides? I assume it's the family that decides mediation or conciliation?
I think so, but I think for their purposes, unless they are involved in a court case and there's legal people involved, like lawyers are involved, I would say conciliation is what I would recommend, and what I think the process will work better for them, I think, than a formal mediation. I think it'll be quicker, and again, you might get somebody that will go in as an independent and charge a way discounted rate, but you might not have that with a mediator. So I think that's one of those things that when you give power to the people, like, you can ask them, you can explain the difference and say, which one would you prefer? Here's why on this side. Here's a list of mediators that we've used in the hospital. Here's is there somebody in your family that has any skills at dispute resolution? And sometimes there is. Or social workers and chaplains do this a lot. And so those are the people that are someone in HR. They are trained in mediation and dispute resolution. So really, that would be the cheaper option, and the one that's gonna get what everybody wants in the end a lot quicker.